how you doing, man? Good. Hold on.
Hey guys. So we'll give it a couple minutes for everyone to kind of continue to log in. I'll make one more social media blast.
How's everyone doing?
Hey Jason.
How you doing?
Who's going to be sharing their screen? Is it Omar or Shaber?
Omar's got slides. We tested them out. It should work.
Excellent. Great.
Hey, everybody.
Hey, man. How you doing?
How are you?
Thank-
Hey, Randy.
Hey
Thanks for
Shaber.
joining us.
Jason.
Thanks for joining us.
Of course, of course. Thanks, Jason. I'll put my white coat on. Good to see you guys.
You too, man.
Happy Thanksgiving to all of you in advance.
You as well.
Yeah.
A little bit of a damper on Thanksgiving, though, with the CDC guidelines and COVID. And
Yeah, our own family Thanksgiving has been canceled, and so I imagine that's. Happy Thanksgiving to all of you in advance.
You as well.
Just I think Nitesh, just mute the background stuff.
I did. I muted
Yeah,
it out.
great.
Sorry about that.
No worries. All right, everyone. Well, it's 4 o'clock. Welcome to another edition of Tumor Talk. This is a collaborative effort between Lenox Neurosurgery and the Journal of Neuro-Oncology, where we bring in authors of recent publications in the journal to discuss, the rationale, the reasons, the results, and the relevance of recently published studies. So today, this is part of a series that we're doing in collaboration actually with Rutgers and Dr. Danish regarding laser interstitial thermal therapy. I guess I don't know if I said that right. Lasers for
Good.
brain tumors. It's the short way. But either way, welcome Dr. Danish, welcome Omar. And we tend to jump right into it. It's a 30-minute session. We'll have you guys start presenting. We'll have some interaction with the audience, hopefully, and questions between the panelists. So thanks so much.
Thank you.
Omar, if you want to share, yeah, go ahead.
All right. Well, first and foremost, thank you for having us and giving us the opportunity to talk about our paper. So essentially, we're going to be talking about today is going to be laser interstitial thermotherapy for posterior fossa tumors. And really, over the past decade, LITT has seen quite a bit of use both in epilepsy and for intracranial tumors. And the world of neuro-oncology has been used for both primary and secondary brain tumors. And there's a lot of draw to it, right? You get the real-time thermal damage estimate with MR thermometry. You can access, conventionally hard-to-reach tumors. But despite all its use over the past decade, there hasn't really been much reported of its use in the posterior fossa specifically. There have been a couple papers. I think the largest one to date had been 13 patients coming from the MD Anderson group. To sort of address that gap in the literature, we decided to present our own multi-institutional series, which is to date the largest series of patients that underwent LITT for posterior fossa tumors. And so in terms of the study aims, broadly, we wanted to look at 4 things. We wanted to look at the efficacy of thermal ablation for tumors in the posterior fossa, specifically reporting local control. We wanted to look at the safety profile, reporting both the procedural complications as well as neurological deficits. We also want to look at hospital length of stay and readmission rate, and then finally look at postoperative steroid requirements in these patients. So in terms of methods, like I alluded to before, this is a multi-center retrospective study between our own institution, as well as the University of Miami, Emory University, and Henry Ford Hospital. This included all patients that underwent LITT for a posterior fossa tumor. And in terms of the endpoints, sort of like I said before, number 1, we looked at local control. And this was essentially defined as any lack of progression. And for progression, we defined it as enhancement that increased in size by a minimum of 25% in 2 dimensions on 2 consecutive scans. And this was typically spaced 4 to 12 weeks apart. And then, of course, all the other things I said, looking at postoperative complications, length of stay, 30-day readmission rate, as well as the postoperative steroid requirements. And so in terms of the procedure itself, all cases in this study were done using the visualized thermal therapy system. But I think there are a couple of salient points that are worth mentioning specifically for, LITT in the posterior fossa. In this specific study, we used a number of different laser insertion approaches, including both frame and frameless-based approaches, as well as some investigators using things like the ClearPoint system, as well as robotic assistance. But specifically for some of these tumors, there are certain cases where certain approaches may be more beneficial. Let's take this patient, for example, who had a pineal region tumor. At the end of the day, the goal of LITT is to orient the laser trajectory along the long axis of the tumor. And in this patient specifically, what that required was an insertion point that was quite inferiorly placed. So while frame-based approaches might offer that exceptional sub-millimeter precision, the best way for us to sort of achieve a more flexible trajectory involved using a frameless-based system. And the way we typically do this is with skull pins for registration, and then laser insertion with the Medtronic Vertec arm, as well as a precision aiming device. And sort of that allowed us to hit this trajectory and get good ablation. And so obviously there's other anatomic considerations as well in some of these patients. And so take panels A and C, and these sort of demonstrate 2 seemingly similar tumors in the brainstem. But we chose completely different trajectories. And these are all anatomic considerations that sort of go into place. For the patient in A, essentially what we ended up doing was actually taking a transfrontal trajectory, whereas in C, we ended up taking a transcerebellar trajectory. And again, it's all going to be dependent on the morphology of each individual tumor. And then finally, the posterior fossa sort of presents these sort of traditional anatomic boundaries. And so take this patient who had a cerebellar vermian tumor. Specifically in this case, what would have allowed for adequate ablation was going to be a transoccipital transtentorial trajectory. And then in C, you can sort of see the planning of that, and then in D, you can see actual implementation of the laser trajectory across the occipital lobe and across the tentorium. And so in terms of actual results, we had a total of 58 patients in the study being treated for 60 tumors, mean age of 56. And in terms of actual breakdown, in terms of location, we had 7 brainstem tumors, 52 cerebellar tumors, and 1 pineal region tumor. And the majority of these patients, 91%, had some kind of prior intervention, whether that was craniotomy, stereotactic radiosurgery, or a combination of the both. And so in terms of demographics, like I said before, mean age of 56, the majority of the patients in this series were female, 40 patients versus 18 male. And then in terms of actual pathology, we sort of see a breakdown in terms of tumor location and primary tumor pathology. And so one thing I do want to note specifically is our own institutional use of the term infield recurrence. Essentially what we define institutionally as infield recurrence is recurrence within a previously radiated field following stereotactic radiosurgery of a metastatic tumor. So typically when these patients present, typically we think of things like radiation necrosis or recurrent metastasis. In our own institutional experience, we felt that LITT provides adequate control of both. So we typically sort of lump them into one term, infield recurrence. And by doing that, we sort of bypass an often expensive and sometimes inconclusive workup trying to differentiate between the 2 pathologies. And so just looking at sort of the different tumor types, within brainstem, most of the patients treated had glioblastoma, 2 patients that have infield recurrence, and 1 was an ependymoma, and the majority of cerebellar tumors were secondary tumors with a couple of primary tumors as well. And then of course, 1 pineal region tumor as well, as I mentioned before. So in terms of operative parameters, the things we look at are going to be the preoperative target volume, the laser power, ablation time, number of ablations, as well as the trajectory length. And there's 2 things I do want to point out specifically in this table, that being the laser power as well as the post-ablation and pre-ablation volume ratio. So typically looking at laser power for brainstem tumors, we do try to ablate with minimal power. And that's typically to try to avoid collateral damage to surrounding neural tissue. And in terms of the actual post-ablation or pre-ablation volume ratio, the way we took this was looking at the 24-hour ablation volume and dividing it by the pre-ablation volume, tumor volume. And essentially what that does is it sort of gives us an idea to look at the extent of ablation. And sort of going along with what I said before, the extent of ablation for for brainstem tumors was lower than that in the cerebellum, though it wasn't statistically significant. And in terms of local control, we had, of the 40 or 58 patients in the series, 48 were available for long-term follow-up. Local control for these patients at a 9.5-month follow-up period was 84%. And then breaking that down by tumor pathology, primary tumors had a local control rate of 60% versus a local control rate of 90% for secondary tumors. And then again, looking sort of at the relationship between recurrence and extent of ablation, patients with recurrence did have a lower extent of ablation compared to those without recurrence. But again, this wasn't statistically significant, but sort of just shows us the overall trend of this. In terms of the complications, we had 2 procedural complications in this series. One was catheter misplacement, in which the patient ended up undergoing standard craniotomy and did well, and another one in which the patient actually had a superficial insertional hemorrhage. In that case specifically, we felt that it didn't pose a risk to either ablation or the patient, so we actually continued with ablation, and the patient did well postoperatively. In terms of new postoperative deficits, or no, not new and worsening postoperative neurological deficits, 4 in 7 patients with brainstem tumors to develop these either new or worsening deficits, and 8 in 50 patients cerebellar tumors developed some either new or worsening neurological deficit. The difference between these two was statistically significant. And in terms of actual improvement at follow-up, 5 of the 12 patients had persistent deficits. 4 out of the 12 had some partial resolution. And there's complete resolution in 2 patients. And then 1 was placed on hospice before we could, fully assess improvement. And there was 1 mortality in the series. Specifically, this was a 6-year-old gentleman who came in with a midbrain glioblastoma for, I believe, it was about 6 cubic centimeters. Postoperatively, he developed quite a bit of refractory cerebral edema. And actually, the T2 flare image is shown on the right. And sort of what you can see is quite a bit of hyperintensity surrounding the ablation cavity post-ablation. And so this is actually just a breakdown of all the complications that we had in this series. And it sort of has a lot of information, but I think the important thing to look at here specifically is going to be sort of the extent of resolution of these postoperative deficits. So for a lot of the brainstem tumors located on the top, these patients typically had persistent or partial improvement at follow-up, and this actually carried through for the patients that had lesions specifically within the cerebellar peduncles. However, those with lesions located specifically in the cerebellum typically had either partial or complete resolution. So you sort of see some trends there in terms of the location and when patients had deficits. In terms of hospital length of stay, the average hospital length of stay was 2.5 days, a median of 1 day, but then again, breaking it up by complications, patients with complications had an average stay of 4.8 days and a median of 3.5 days compared to patients without complications, in which they had 1.75 days and a median of 1 day. And this difference was statistically significant. And looking at the 30-day readmission rate, we had a total of 0% in this entire cohort of patients. So another component to look at when you look at the efficacy of thermal ablation is going to be whether or not patients who had or who were on steroids preoperatively, whether they were able to achieve steroid freedom on follow-up. And so 8 of the 38 patients with long-term follow-up were on steroids preoperatively, and about 50% of these patients were able to achieve steroid freedom. But on the other side of that, 30 patients weren't on steroids preoperatively. 9 of these patients were on steroids at last follow-up. And that's typically either due to postoperative neurological deficits or worsening of preoperative symptoms. So really, when we look at LITT in the posterior fossa, we had good control rate for secondary tumors, upwards of 90%. But when we look at primary tumor pathology, it's only around 60%. And really, when you look at posterior fossa, you want to look at the safety profile. We had an overall complication rate of around 20%. And when we look at some of these patients, a lot of them didn't have resolution at most recent follow-up. So, 5 out of 12 patients had persistent deficits and 4 out of 12 had only a partial resolution. So really, when it comes down to it, really the take-home point is when you decide to intervene for posterior fossa pathology with LITT, it's really going to come down to patient selection, just like any other neurosurgical procedure. In terms of limitations, 10 patients were unavailable for follow-up, so that sort of potentially introduces some level of survivorship bias. We had 9 different tumor pathologies between 58 patients, and sort of while this sort of serves to illustrate the wide breadth of LITT, it doesn't really provide any convincing evidence for any single tumor pathology. And we had a significant preponderance of secondary tumors, 45 versus 15 primary tumors. And again, sort of in this study, we sort of lumped together cerebellar and brainstem tumors. And sort of, we tried to separate the two, but again, they are very widely different pathology. So it's hard to directly compare the two. Thank you.
Thanks, Omar. First off, I mean, great job. I think that, I know, Shower, you've been a proponent of this for a very long time and really, pushing the field forward for LITT. And I think your experience is probably, not really paralleled elsewhere. And I think, bringing in the other institutions was a great idea and a great job. And expanding the use of something that I think does have use in modern neurosurgery. I guess, to break it down at this point in your practice, what do you see as the indications for this? Looking at the data you just presented, and how do you now choose to do this or not in a posterior fossa case?
Hey, everybody. So, Randy, that's a great question. I think my own practice, and as well as the practice of, other people who are involved in this. I think if you get involved today with laser therapy, it's very different than getting involved 10 years ago, of course, because there's thousands of case experience, a lot written on it. And so some of even the complications that Omar is discussing, some of those are from 9 years ago, which would actually never happen today, So I'll give you, one example for cerebellar hemangioblastoma, where it's 9 or 10 years. And now you think about it like, oh, it's silly. Why would you even try to put a laser in it? The problem is the cyst. And, as a young attending or in a young program, you have patients who are recurrent, don't want a craniotomy, and you sometimes can get swayed even in your own thinking that maybe this might be a good idea. But in this point in practice, for example, I almost would never even offer it. It would not even be a thought, to offer a procedure like this for that indication. I think in the posterior fossa, so why is the posterior fossa different? I mean, I think some of it is intuitive for us. It's a much smaller space. So that in itself, I think, is not the issue. That part is intuitive. But what is less intuitive is how we define what is actually a problem. So one of the home runs in this technology is this idea of recurrent mets. And I think one of the challenges, and it's good actually that Dr. Sheehan's on too, as editor of JNO, is one of the challenges is that when we try to discuss these issues in our literature, is this idea of the biopsy. So, whereas of course we all have a desire to understand the underlying pathophysiology, I'd say in this one instance, I'm not sure that it makes a difference. And this is a little bit of a gray zone in the laser world. Whereas some will argue that there's less control in a pure recurrent met versus pure radiation necrosis. The challenge, there's a couple of challenges in that, is that many instances the pathology is mixed, the histopathology is mixed. Two is that you're often getting that data from a needle biopsy, which may or may not be representative of the entire specimen. Three is that the underlying histopathology may not actually predict the radiographic behavior of that lesion. So in the posterior fossa, because you're in a tighter space, that means that you have to make a decision earlier about using this procedure if you want to do it. So as these things get bigger and they cause more mass effect, once you have something that causes massive, symptomatic mass effect in the posterior fossa, the laser is not a good option for you. You have to approach that pathology with this technology before that's an issue. So why the posterior fossa is unique? Because we as surgeons have to change what we define is either a problem or a potential problem in that scenario. Because if you wait till there's mass effect or they really need steroids, then this is not an option for them anymore.
Yeah, I see. I mean, I think what's important to understand for people watching, and obviously this is open to questions from them as well. We have a mixed, diverse group of people who pay attention or who sign on to follow us, is that in metastatic tumors in particular, these patients have been through chemotherapy and radiotherapy already. I mean, I looked at the size of what you guys presented for the most part, and it seemed like the average size was about what you would consider for something like gamma knife radiosurgery, but that's already happened. There's no other option here really, except for whole brain or systemic chemotherapy. So you're offering a surgical option with, especially in metastatic tumors, based on what you're presenting, excellent control rates.
So one thing, yeah, to be clear, is that at least in this series, for recurrent mets, cerebellar gliomas are much more rare. And I'd say that doing laser therapy on them is also a much more rare situation. But none of these in that recurrent mets population were ever upfront treated with laser therapy. They're all radiation failures. Now, I think the one question that is a valid question is there are instances in which you can re-irradiate a prior radiated tumor, and there are series that will report fairly decent outcomes in that scenario. The radiation necrosis rate goes up, but this is ultimately becomes a play on numbers. And I know, Dr. Sheehan, you have published a lot. You've moved the radiosurgery field needle to the right in a lot of different ways. I'm very interested in your viewpoint on that, because I'd say institutions are different. At my particular institution, no way am I convincing the radiation oncologist to redo radiosurgery in the same spot in the notion of infield recurrence.
First, let me start off by saying I think this study that you've done is a very impactful one, and my hat's off to the fact that you're able to pull this together as a multi-center experience. I think you and your colleagues have led the way in terms of this emerging approach for treatment of recurrent tumors, of both primary and secondary, as well as for radionecrosis. As you've touched upon, I think it's very clear that although we oftentimes like to say, oh, it's necrosis or it's recurrent tumor, it's oftentimes not binary. It can be a mixture of the two. And even within the same volume, much less a few millimeters away, I've seen specimens where I've resected where you see a mix of necrosis and an adjacent viable tumor. And there's no role for repeat radiosurgery in the setting of a patient who has a purely radionecrotic tumor. But you can retreat some patients who have purely viable tumors. The challenge, of course, is that mixed response you may get by a mixed underlying tumor histology. But I think LITT offers a lot of different mechanisms of action that could both deal with both scenarios, both the necrotic tissue as well as the viable recurrent tumor, if there is any present. And one of the questions I had was just a thought about when you're doing the procedure, are you giving these patients added steroids for a period of time, either peri-procedurally or even longer?
So I'd say my own personal routine has been to put these patients on a steroid taper for a week or two. I basically just made that a routine. And I'll fully admit that just doing it for everybody just makes it easier in terms of managing, just how the patients are cared for and then dealing with in the outpatient setting. If you go through the energy of tailoring it, I think that there are patients who could avoid it altogether. I'll fully admit that it's on an algorithm and the push of a button and everybody gets a taper.
Yeah.
When you're defining these the trajectories you're taking, I think the Omar had said earlier, it's based upon the location of the tumor and the surrounding structures. But are you using DTI? Are you using other types of imaging modalities? Or are you principally using neuroanatomically expected structural locations when you're planning your trajectory? How sophisticated are you getting, or how in 2020, what do you think is sort of the standard when you would go after a brainstem tumor with LITT? What would you do?
I think Jason's a great question. So the majority of these are deep to the surface, but I would say not necessarily in critically eloquent, parts of the brain or near the. Now, it depends on how you also define that. I'd say the Visualize software in this moment does not allow you to put in tractography into your ablation software, which is different from NeuroAblate. The MRgLITT software will allow you to do that. So if you have a system which allows you to easily do that, I think I would be the same as many others, say that more information or whatever potentially makes these procedures safer is how we should do it. I have done 95% of my cases with visual aids. I think that change in the software is coming in the next year, where we will be able to put DTI in. Now, one thing I will make a comment of is that if you have a tumor or a target or recurrence that's really sitting in or near Broca's or in or near Wernicke's or arcuate, or really sitting in the motor strip, I think that sometimes the misconception is that since this is a 2 millimeter hole, it potentially is safer. And I say after years of doing this, I probably think the reverse. If I really think that something is sitting in motor, just for example, I think I become an advocate of opening it up, monitoring it electrically or awake, and then doing that resection. I think it's much safer for the patient. The ablation, no matter how safe you are, the patient's completely asleep and you're ablating. And there's not only the damage from the ablation, but there is going to be secondary effects from post-ablation edema in that setting. There are a couple of centers around the country that are doing or trying to do ablations awake, but it is a tough proposition. These patients really have to stay still, and that's a rare patient who can do that.
Yeah, definitely.
If anyone's going to get to MRgLITT and make it mainstream, it'll be you and your team.
And also, I want to make sure that, in this talk, I'm one of 4 or 5 attending. So, this work represents work by Rick Komatar, Ian, John Willey, who really have also helped, pave their, the paths of their own institutions. And I think those are the, those groups that are involved in this. We look at LITT as analogous, maybe a couple decades behind radiosurgery, where we hope that by combining institutional experiences and hopefully by one day having the ability to collect big data, do it prospectively, that we'll be able to make the kinds of, move that needle in the way that you and your colleagues did for radiosurgery.
Yeah, absolutely, man. That's great. So I got to ask you, for infield recurrences, are you biopsying or no?
A great question. I'm going to say this, out in the open, because I know Dr. Jason, you're the editor, that I think that if you don't think that the biopsy is going to change what you ultimately do for this patient, then the only thing the biopsy does is potentially make that laser procedure more complicated. And let me just give you an example. That it is we would all like to think that we get the perfect biopsy specimen from that first pull in that biopsy needle. But we've all been there where it doesn't happen. You get a little blood, or you get just, a blank shot. And then you're turning your needle, you're pulling again, or you're going a little more superficial. And what happens when you do that is that you're introducing air and blood into the cavity. And when you introduce air and blood into the cavity, that laser therapy, the thermal energy will not distribute evenly. And no matter what system you're using, that registers a signal artifact on your thermal imaging. And when you have signal artifact on your thermal, and we've published on this also, that your boundaries are inconsistent, your thermal damage estimate is inconsistent, and then you force yourself into somewhat of a blind ablation. Now, this is not the case if you're dealing with, I think, a recurrence of some type of primary glioma. I think in those scenarios, the primary gliomas, when they recur, you have different expression of receptors. If you really have radiation vasculitis pathology that is progressive, that makes a real difference in what you do with that patient afterwards. But in the infield, recurrence for a metastasis, you're not using that information most times to change the systemic treatment for that patient. This is a focal problem in the brain. So I would argue that I don't want to turn into biopsying these things just to make sure that I get my research published. That's not a good reason to do it. But I'm telling you, but the experience is, it's become challenging. And even with this, with this publication, I'd say it was somewhat variable. And I know we're not talking, we recently also published a survey project, which was done through the CNS. And that was, I'll piggyback that conversation off of this because it's relevant, where we sent out surveys to about 400 neurosurgeons who defined themselves as neurosurgical oncologists. And in that study, what we found was a variability in practice, not laser therapy, but variability in the steps before that. How do you define recurrence? What modalities do you use to differentiate between radiation vasculitis and or recurrent METs? When you have a biopsy specimen, how do you define recurrent MET versus radiation vasculitis? Is it one tumor cell per high power field? Is it 50%? Is it some necrosis, all necrosis? The problem is that the answers were all over the spectrum. So if we can't come together and in being on the same page about how we actually define those entities, then we're going to spin off into a tangent for everything else we write about this stuff. Does that make sense, Randy?
Yeah, absolutely.
Yes.
Jason, you got anything else? I mean, we're approaching the 30-minute mark. We like to keep these short and sweet so people stay paying attention. But
agreed. I think people were paying attention. I certainly was, and I think it's impactful, meaningful, and I agree with your sentiments. You always want to do what's right for the patient in the end. The publishing will follow as long as you do that. So thank you so much. You guys have done a great job, and looking forward to more studies in JNO from this group.
yeah, absolutely. And expect my call. My laser comes soon. So I did it at Columbia. I'll be starting up over here. So I'll be calling you for advice.
Got another center to accrue.
Yeah, exactly.
Thank you very much for inviting us to do this.
Happy Thanksgiving, everyone. Bye-bye.
Thanks, guys.
See you guys in a few weeks. Take care. Bye-bye.
Take care.